Hey, this is Dr. John Bennett from Miami, Florida, on another series of the Boston Medical TV series of Google Hangouts, mostly with people from the Boston area, talking about advances in digital healthcare. Tonight we have the pleasure of having Cole Zanetti D.O from Dartmouth. He's up in Concord, New Hampshire. He's going to talk tonight about the potential of big data and its innovative applications. So good night, Cole.
Thank you very much, and thanks for inviting me, John. I really appreciate it.
You're welcome. Okay, I guess you're going to give your presentation, and I'll just ask questions at various times, and take it away.
Absolutely. So big data is a term we hear a lot about in healthcare, and it's kind of an ambiguous term. And I think that a lot of the times, especially as we're encountering a new healthcare reform, we're looking at ways to capitalize on the things that the business world has been capitalizing on for years, and that's taking advantage of data that currently exists to try to provide better care. The first thing that I think people think about related to data or information in medicine is the electronic health record. And how do you utilize the electronic health record to better provide care and take advantage of all the wealth of information that's there? I know for one, for me, we put about half of our time dedicated to putting information in a chart. Most of the time it's been used for billing and to establish a narrative between visits. But some exciting things are going on related to that data that allows us to make it more actionable. And I'd love to tell you a story about this great project that occurred down in Parkland Hospital in Dallas, Texas, where this incredible physician, essentially who also had a background in programming, helped create a predictive analytics system, which is a fancy way of saying using statistical modeling to identify correlations in data to a particular outcome. So essentially, think about congestive heart failure, because this is what the project actually did. They were trying to see, how do we make the information that we have in our electronic health record actionable so that we could try to reduce 30-day readmissions. What they were able to do is look at their historical data about all of their patients within their specific community, and they were trying to identify what correlations exist or existed between those patients that were frequently admitted within 30 days to identify the risk factors that were already within their charts, that were specific to how their system collected the data and were able to be extracted in the moment at admission. So they were able to create an algorithm. Think of a common algorithm that we use today, like the Framingham risk score. Imagine if you were able to customize that and use it in real time. That's exactly what they did. They have Epic, which is an electronic health record system that is called an enterprise. That means it actually wraps inpatient, outpatient labs and other healthcare entities together. They built that program on top of Epic so that if you're a physician and you're admitting a patient in with congestive heart failure, once you put the orders in and the preliminary data, it was able to extract that data out in real time and give you a risk score for that specific patient. And that risk score was created from the algorithm that was established from your historical data. They were able to use that risk score to better allocate resources within their institution, because like most community health centers or community hospitals, I should say, you don't have that many resources, and you're taking care of a very vulnerable patient population. So having a better way to allocate those limited resources to the patients that need it most is incredibly important. And that's exactly what this allowed them to do. They implemented this system, and they were able to reduce congestive heart failure readmissions by 26% without hiring any new staff. And it's things like that that impact workflow in real time that allow us to better coordinate care. That I think when you think of big data, these are the things that I tend to gravitate towards. There's also a lot related to remote monitoring. There's great new applications and new tech that's coming out, even the Apple Watch, for example, and the potential of that to add to the data that's being collected. My personal take on remote monitoring is that the thing that's going to be the greatest hurdle for it is related to the extra step people would have to take, either to put a device on or to input data. It is a deterrent for a lot of people to utilize it to its full capacity. If you look at some of the data related to a lot of health apps, as an example, there's a lot of people that will download it, and once they are about to input data, let's say it's about the dinner they're about to eat, people realize that it's rather cumbersome just to do that, and they'll use it for about a week with a lot of effort, but then they'll stop and they won't use it again. You know, as a personal example, I have the Nike Fuel Band, and I loved it for the first week, but I never wear watches, and I always was I always laugh when I saw a TED video that's very well known. It's by Sir Ken Robinson. And there was one moment in the video where he asked the audience, everybody that is age 30 or over, please raise your hands. And everybody did. And then he asked, how many of you are wearing watches? And most of them kept their hands up. Then he asked the audience, who here is younger than 30 years old? Please raise your hands. Now keep your hands up if any of you are wearing watches. And 90% of the hands went down. And there's a generational element to that, because when you have a multi-purpose device like a cell phone, there isn't a reason to carry or to wear a watch anymore. And the more and more elements that are built within that singular device, it makes many interactions much more user-friendly, and it doesn't require the extra thought process of doing something to achieve that benefit. So there are hurdles with remote monitoring that are intuitive, but to take it a step further, let's say that you have 4 Fitbits in your home because you're trying to track the health of your family. What if your son accidentally picked up your Fitbit and walked around that day with it? The personal identification aspect of these techs also adds another layer of complexity. So there are some finicky elements to some of the remote monitoring components that are still trying to be worked out. But there are also some really brilliant big data collection that's more seamless. I would refer to Ginger.io as an example of tapping into data that is being collected based on patients who choose to partake in this process to improve their mental health, to create a more sensitive pulse of what's going on related to a patient with significant mental health disease. The Ginger.io group has tapped into data that is accessible on that patient's cell phone related to how many social network connections they have, how many phone calls they make, how many text messages related to their friends, to see, is there going to be a heightened or decreased level of isolation that we should be worried about. And this kind of taps into some of the issues related to security. You can't talk about big data and not the security and privacy issues. Those are going to be major hurdles, and legitimately so. Patients are going to have to either opt out if you use what is it called, a libertarian approach to how we're asking patients about their privacy, or we're going to have I think a more public discussion about how to address these issues. I mean, Target, as an example, when they apply predictive analytics to identify when some of their customers were likely to be pregnant, thus send them coupons so that they were able to purchase particular commodities related to their level of pregnancy. They also got some major public heat related to that. Although, if you think of that intuitively as a consumer, it's helpful, it makes sense to some degree. But it's also kind of frightening to think, just by shopping and being there, they could know things about me. That's something that I think Americans really have a hard time with, and it's going to be a challenge for big data.
Well, I'm like most physicians, Cole, because this is a new. I did a little reading before talking tonight, and basically this is a new science. Matter of fact, it was just put in the dictionary last year, as far as the term, big data, as far as being a term that's defined officially. So you're speaking. I think 99% of physicians really don't have any idea. That's why it's called a new science, and I thank you for coming out tonight. Now, just a couple of general questions. One of the articles I wrote, they had 40 different data scientists define big data. In other words, no one was really positive about exactly what it is. How would you define big data, Cole?
Well, that's a really hard question.
Yeah. Oh, yeah. 40 different ones.
Yeah. To be honest with you, I have to simplify it in a way that makes sense to me. To me, it's almost a digital representation of our behavioral existence.
Okay.
It's any fragment of information or data that is collected about behavioral activities is what I would deem as big data.
Okay. Matter of fact, one of the gentlemen described it as being it's not the data that's big, but it's a number of devices that's big, and sensors. He said that, I was surprised when I saw that. I said, oh, well, it's not the data that this is just one of the 40 definitions, but he said that it's the number of devices that's big. It's like you mentioned, the number of wearables and devices and sensors.
Well, it's a good point. I mean, there are so many places to collect data. I mean, to be honest with you, though, to think about where, there are so many places that have data right now that aren't sharing it. I think a perfect example is of a typical state government, right?
Okay.
They have multiple departments. Multiple departments with massive quantities of public data, and most of those institutions are siloed. I mean, those data points aren't even shared on most occasions between those departments, so that, let's say, big data could be fully accessed. We tend to fragment things and separate them into a reductionist point of view because that's how we can better understand them. What big data as a movement, I think, is saying is that all of those components of data are a part or a perspective of the reality in that moment, and that to bring them together to collectively better describe what is going on is the value added related to big data. I think the sensors and more and more data collection that occurs around this country are going to allow that perspective to become a little bit more granular,
Mm-hmm.
but you're going to have to basically tease out what is important and what is garbage related to whatever specific question you have. And that's where you can't talk about necessarily big data without the vital importance of analytics that
Right.
has to be partnered with it to make it valuable.
Or filter. Could you call it like a filter?
Yeah.
Well, you know, that's, to me, not knowing much about the field, I would think of course, as you alluded to, it applies in business also, the analysis of data. But in medicine, it would seem to me that it takes like a doctor, to analyze the data, more or less. Is that true?
Well, I think that it takes multiple partnerships. I think in medicine, when we talk about team-based care, you know, we typically think of the typical players in healthcare. You have physicians, nurses, medical assistants, physician assistants, and nurse practitioners, you know, administrators, so on. I think what is important about big data in interpreting it is to realize we have to be more expansive in how we define team. You're going to need physicians to some extent to provide contextual perspective. You'll also need sociologists, anthropologists. You'll need, you know, various groups that you might not initially think of, but as we collect data, I mean, ultimately we're assessing behavior, but it's how do you take the data that's written in a you know, in a clinic, transcribe it into a meaningful way for application. And another aspect is not just the translation, but how do you make it so that that information will impact decisions in the moment where it's most valued,
Mm-hmm.
right? Just having the information, to me, isn't as useful when compared to having it at the right moment so that it can affect the care and quality of care of the patients that I'm taking care of.
You know, I'm curious, and I have to read about that study down in Dallas for congestive heart failure. And that was like a pilot program, the first time it's been applied clinically in the U.S.?
I think it's the most well-established one. They not only compared that particular risk scoring to they did a cohort study where they had some controls, and they also used other risk algorithms that the Center for Medicaid Services uses or suggests people to use, and it proved more effective than what's out there. And anybody can, I guess, think through that to make sense of it, because if you're creating your own algorithm based on your specific patient population data, of course it's going to be better than you know, a typical evidence-based alternative that might not be perfectly aligned with your patient population. You know, that's Paul Batalden, who's a major leader in quality improvement, said that there are two vital components to achieve improvement in a system. One is evidence-based medicine, and the second is particular context. And I think that we've worked very hard, and we continue to work very hard on the evidence-based medicine part of that equation, but we struggle to appreciate the particular context variable. And I think that's where big data will add the most value, is through the context.
Right, and the doctor should be the one to determine that, correct, or to apply it?
Absolutely. I mean, you have to have healthcare professionals as partners to help transform and mold that opportunity. It could be physicians. I also think that care managers could be a huge player in that. At our institution, where accountable care organizations are proliferating, you have positions like nurse navigators, who their sole job description is to try to better manage the high-risk patient population. So those are patients with high disease severity and high risk factors. And they're looking exactly for this. But it's going to take physicians, care managers, and to be honest with you, patients themselves to help us make the most value achievable through big data.
Okay, boots on the ground. How did it work in Dallas? What kind of information, is there any specific information that you could tell us that was received to make it a 26% better outcome?
Yeah. So I think, you know, for me, it helps to understand something when you think of what patterns or correlations did they identify that helped them figure out the heightened risk, right?
Right.
And one of the things they were able to identify was the amount of times that patient that was being admitted changed their home address.
Okay.
Right? So it was a sign of lack of resources,
Right.
needing to shift from one place to the next, and that was a key risk factor identified. The boots on the ground element was that risk score went immediately to the social workers and the case managers, which were of limited number in this community hospital, so that they were able to prioritize the time spent with these particular high-risk patients. So they were continuing doing their regular work. They weren't doing anything differently. They just were able to allocate their time to those that needed it most during the hospital stay. And that's what made the difference.
And it doesn't sound medical, changing addresses. That's just like almost an extraneous fact.
Well, you think, I guess one of the things we struggle with is in medicine, because we spend most of our time just learning, the pathology of why these things happen. Unfortunately, or fortunately, I guess, to some extent, a lot of the reasons why these people are at such high risk are related to social determinants of health. And we know this. I mean, healthcare impacts maybe 10 to 12%, depending on what research you're looking at, but about at most 20% of the health outcomes of our patients. So when we realize things like this in risk algorithms, it shouldn't be as much of a surprise as it is, because most reasons why these patients are struggling so much are related to those social determinant of health issues.
Well, I guess you would come upon that fact about moving in the social history when you take an exam. But I guess you're in preventive medicine residency now up at Dartmouth?
Yes, sir.
Now, so is big data kind of an innovative thing that you guys are doing during your residency studying?
So there are different elements of that. I'm the first preventive medicine resident at Dartmouth that's really pursuing big data full-heartedly, and I'm doing it in a little bit of a different way than I think most people around the country are. For example, when I described to you the Dallas hospital example, and what you typically hear about are overutilizers. Are those high-risk patients that are admitted to the hospital repeatedly due to their chronic disease exacerbations. And we have amazing professionals working very hard to try to address that patient population. New positions like nurse navigator have been created just for that. We hear about the hotspotters, Jeffrey Brenner, and there's a lot of intrigue to try to address the complex issues of that specific population. Unfortunately, due to the urgency related to those complexities, we have not had the opportunity up until this point to be able to step back and look at the other side of the bell curve. And that other side of the bell curve has some of the answers to those complex questions that we're asking for our overutilizers. The other side of the bell curve are the positive deviant patients.
Okay.
Those are the patients that have the same high disease severity and the same
Right.
high risk factors as their overutilized counterparts, but for some reason, for years, year after year, they've been able to better manage their conditions, thus proving better outcomes at reduced costs
Okay.
within the context of our own dysfunctional healthcare system.
Okay.
So I'm currently researching, studying these particular positive deviant patients with the nurse navigator and the primary care teams to identify the behaviors and strategies that they've been using that allowed them to be successful within the context of our system.
Can you give us some quick examples of those types of behaviors?
Sure. So positive deviance is actually a fascinating field, and it's been applied to multiple sectors, including healthcare, education, nutrition, and social atrocities within the United States and around the world. But the behaviors, those little things that you're talking about, are just so fascinating and I think endearing to community members' hearts because it's so practical, it's pragmatic. And of course, people that are in such high-risk scenarios and have such limited resources, for them to be able to coordinate and identify the elements that allow them to succeed, it's within the bounds of relatability to others in a similar position. So I'll give you an example of, I think, the first positive deviance story, just because I feel like it gives the best depiction. And then I'll give you some healthcare examples of what has been used.
Okay.
So it started out in Vietnam, where there was a group of people, the Sternans, Jerry and Monique, who were working with Save the Children. And they were going to Vietnam in the early 90s. At that time, the United States actually had a tariff against them, or I'm sorry, an embargo against Vietnam. So the political situation there was a little bit heated. When the Sternans arrived, they were told by the political regime that you don't have 6 years to work on the issue that we're going to ask you to work on. You have 6 months to prove us that you can obtain results, or else we're going to send you home. And the thing that they were working on was related to early childhood malnutrition. At that time, 65% of children under the age of 5 were malnourished in Vietnam. And they told them to go down to the most severe community. When they went down there, they realized, they can't roll out an evidence-based protocol in the time duration they have. It's not realistic. So they thought, if 65% of children are malnourished, there's still 35% that are not malnourished. Who out of the 35%, based on all the knowledge that we have about risk factors related to early childhood malnutrition, should be malnourished but are not? So those with all the risk factors but are healthy. So they asked the community, is this something that you care about? They
Right.
absolutely said yes. And they worked with the community to identify those positive deviant patients. The behaviors that they identified was that the positive deviant patients were picking little shrimp, little crabs, and sweet potato plant tops and putting it in their stew that they fed a little bit more frequently to their children
Wow.
than the others that were high risk.
Wow, that's fascinating.
So those little elements, and those are resources that were locally accessible, but you have to realize that those resources were not necessarily accessible in the next community. So the important reality of positive deviance is acknowledging that you have to restart that process in each community that you go to, because the complexity of resources and system dynamics is different in each community that you go to.
That's fascinating. So now doctors will have to become acquainted with positive deviant behavior. That'll become into the vernacular, and today was actually the first day I've heard that phrase.
Oh yeah, yeah. Well, it's an absolutely fascinating field. The first research in healthcare related to positive deviance took place in Pittsburgh, Pennsylvania, and it was led by Dr. John Lloyd, who was head of the VA system quality initiatives. They were rolling out TPS, like a Six Sigma and Lean initiative at that time, to try to address hospital-acquired infections. And they were able to reduce the hospital-acquired infections using that methodology, but they were having a very hard time spreading it to the other units. Plus, it was cost prohibitive because you need experts to train everybody in how to do this stuff.
Mm-hmm.
So he read about that Vietnam case and called up the Sturtons and asked them, can you help us apply positive deviance to this situation? They did, and the people that contributed were not just physicians. The people that contributed consisted of clergy members and janitors. I think the most amazing story was the janitors that were working in the hospital. A lot of them didn't speak English, so they had this thick manual to try to describe how they're supposed to clean the rooms, and no one even knew what any of it said. So between them, they actually created a color-coded manual to clean the room most effectively so that everybody understood. The clergy members, when realizing that they could be potentially contributing to the spread of that disease, they actually put surgical caps over their holy books in order to aid in the prevention of that spread. The whole initiative was to find positive deviant behaviors of those that were able to follow the evidence-based protocol, but they were also looking for behaviors that went above and beyond the protocol that would also contribute. So it allowed people to add the contextual benefits of behaviors that stretch beyond just the healthcare team, and realizing that everybody is a part of the healthcare team if we're to prevent MRSA, as an example. After they did this study, they did a follow-up study 7 years later. They were able to reduce, I have to check the numbers, but I believe it was around 40% of hospital-acquired infections, and they sustained it for 7 years after this modality. They've done it in, I believe, 5 hospitals. I have to check the exact numbers once again, but around 5 hospitals through a Robert Wood Johnson Foundation grant to establish this as an approach to quality improvement.
It's really fascinating, and I think it's such a new thing. And I see now what you mean when you say team approach. When in fact you essentially want to change some non-medical factors in the patient's behavior, in the community's behavior. But this whole field is being investigated, attacked by data scientists that that are working in medicine, and you're on the ground floor. Now you think, Cole, you're one of the first residents to actually spend some time during the residency of family practice at Dartmouth. You're one of the first ones to do this kind of work?
Well, there are other residents that were interested in big data. I think Dartmouth is really trying to align opportunities for big data training or analytics training for their residents. Up until recently, clinical informatics, I think, is the more recognized term in our field. Right. It wasn't a specialty. It wasn't anything. The only way that you could get experience in it is if you were doing a National Library of Medicine fellowship, and there are a few scattered around the country, and there's amazing work going on in all of them. But up until recently, now we have a new field, a whole new specialty that has been created because we realize there is a massive void of knowledge base and a great need for clinical informatics specialists to help kind of migrate our field in healthcare to the forefront of how to capitalize on big data. So I think residencies around the country, Dartmouth included, are really trying to bring in the big data element to residency training. Preventive medicine is definitely a huge area that's doing it, right. But there are going to be clinical informatics residencies specifically where people go and get trained and you get specialized. and they're rolling out. I think Stanford was the first one to get ACGME accreditation this past year, but each one has its own flavor, if you will, just like preventive medicine. Each clinical informatics residency or fellowship has a particular area that it spends most of its time in. Some having to do with genetics, others with behavior, some with remote monitoring. San Diego has more of a remote monitoring flavor. But there's a lot of fantastic opportunities out there, even right now.
Well, I ran across that. It's a board specialty now.
Yep.
Last year, American Informatics. And let me maybe show you on the screen here.
Yeah.
Can you see that okay, Cole?
Yes.
Yeah, that's the American Informatics.
It's the
AMIA.
Yeah, the Association for Medical, or the American Medical Informatics Association, and they've been doing this stuff for years. They've had, I believe, there are certain workshops that people would be able to take. There's 10 by 10 is a training program that's been out there for many physicians. OHSU has been doing great work in that area, but that institution is not just clinicians. It's data people, it's data scientists, it's people that have been doing this stuff for years, also in the business sector. This is, I have to try to clarify, big data is not necessarily new. It's
Right.
new to medicine.
Right.
It's been in the business world for over a decade. Businesses have been utilizing this approach to make more effective strategic decisions. And I would suggest a book, and I have absolutely no conflicts of interest here. I have no relations with these people, but
no disclaimers.
No disclaimers. But
Okay.
there was a book that helped me a lot, kind of getting introduced into this field, and it was called Predictive Analytics.
Okay.
To me, it was like the freakonomics for big data. If you just, I think, I'm trying to remember the author's name, I think it was Eric something, but fantastic book that went into multiple examples of how analytics is being applied to big data in multiple sectors, including healthcare. It actually provided some healthcare examples. It was a easy read to understand what's going on.
Okay, I got it. Let me just show you on the screen there.
Yep.
Cole, I think I've got it. This is the wonders of digitalization. On the fly, I can get to this book. Is that the book you're referring to?
Let's see here. Yep, that's exactly it. It's Eric Siegel. Yep.
Right.
It's a fantastic book. I read it a few years ago to help provide me some better context in what I'm trying to do, and it actually breaks down what's been going on for years. He holds conferences related to this, and the first conference of predictive analytics in healthcare is occurring this year, I think, in Boston. Actually next month, or within the next 2 months.
Okay.
Where physicians can actually take workshops in getting exposure to this stuff. But like I said, I think you cannot talk about big data unless you talk about analytics, and Eric Siegel, I think, is one of those that's palatable for most people.
Well, and you say this doesn't just apply to medicine, correct? This is a general tech.
This is a tool. It is a tool that applies to any entity that has data and intends to make it more actionable for better strategic decisions.
Are you going to that conference?
I wanted to.
Okay.
I've been invited to a few other conferences to present. I've been very thankful and fortunate to be able to do that, but it's now making me have to make very difficult decisions, and that was one of them.
Well, it's been a long memory doing my residency, but I know what that's like. You only have so much time, and or someone told me you only have so much bandwidth.
Yeah, that too.
That's what I understood that immediately when they put it in those terms. I understood immediately.
Absolutely.
But you know, Cole, I'm glad you could come tonight because this kind of platform of the Google Hangout, to me, shows tremendous potential to be able to teach people about sciences like big data, to physicians like me and across the country, because it's an educational need now to reach physicians because, as you probably know, most don't have a clue about this field. And it's new. It's new. It's brand new.
Absolutely. And you know, we're all learners at heart, right? And we're life learners, and I think the humbleness in realizing that and appreciating, you know, that we're not going to be experts right away. That, you know, we have to look for the very pragmatic introductions into this field, and be eager to learn both its potential benefits and its potential harms. Just like any treatment in healthcare, this is another modality of it. So we have to be cognizant and weigh both.
Well, Cole, I'm corresponding with a gentleman that is going to be big in big data, and I'll talk to you after. I can't reveal, you know how it is sometimes with research and stuff, you can't really talk about names and stuff and
Oh, yeah.
study. Okay. If I could, I would tell you, but this gentleman is big in other fields, and I can't mention the fields because that would kind of give away who he is. But now he's working in healthcare. And he's worked in other industries that have nothing to do with healthcare, that he's done a fantastic job. So that is good news in a way, that he's applying his efforts now to the healthcare field. And maybe someday in the future we'll meet and talk about it. And maybe I'll even have this gentleman on a hangout to talk about the work he's doing and how he's applying other types of big data analysis to healthcare.
Oh,
So
that sounds exciting.
yeah, it's great news. So you're going down to Boston to present at a conference next?
Yes, yeah. I was very fortunate. I submitted a proposal for a primary care innovation challenge. It was a national contest, and they were looking for innovative approaches to change primary care in this country. And I was very fortunate to get selected. I was one of the 6 people. And I go down to Harvard Medical School to do my Shark Tank pitch. I have 5 minutes to pitch my idea, and you know, if I hope that everything works out, and you know, my goal here is to spread the word about how practical and pragmatic the positive deviance approach is to start helping change healthcare. And if people hear it and begin to understand its utility, you know, I've done my job. I'm standing on the shoulders of the giants that have come before in the field of positive deviance and patient engagement, and I'm honored to have the opportunity to represent them, and I hope I serve them well.
Well, Cole, I hope to have a regular weekly conference on things like genomics, big data, and other things that are new in medicine, because that's one of the benefits of digitalization, is just the communication and the ability to put on, like right now we're speaking live, and I think eventually medicine will grasp the utility of this type of platform to talk about things like big data. So, well, I thank you very much, Cole. I won't keep you all night, but hang on after I stop the broadcast, and I hope to have you on maybe after Boston to tell us about how things went.
Great.
So, okay.
Thank you so much, Sean. I appreciate it.
Hold on, Cole. Thank you very much.